You're listening to
CRST,
the podcast
from Bryn Mawr
Communications.
Welcome to CRST, the podcast. I'm your host for today's episode, Dr. Marguerite McDonald, and today we're diving into a discussion about the future of corneal surgery. We have several important topics to cover. It's amazing how quickly corneal surgery has evolved over just the last 20 years, and the current innovations are thrilling. So I'm going to be interviewing Dr. Steve Wilson, Dr. George Waring, and Dr. Marcela de Barros, and I'll let them introduce themselves and their background and their specific area of expertise related to corneal surgery. So do you want to start, Dr. Waring?
Well, first off, it's such a pleasure to be here with you all, friends and mentors and heroes. Marguerite and Steve, you really were, in our book, led the charge on so much of what we've learned and why we're even sitting here today. And we've just always really just been just that. You've been our heroes, our mentors, and also we get to call you friends, and that is just kind of the trifecta, and that goes for both of you. So just want to thank you for all you've done, paving the way to allow us to even be here by really kind of creating the space of corneal refractive surgery. So this is George Waring IV. I'm a cornea cataract and lens refractive surgeon and a corneal refractive surgeon at the Waring Vision Institute, Mount Pleasant, South Carolina. And I also want to introduce our co-host who will be speaking as well today, Dr. Marcela Barros, who is doing a corneal refractive fellowship at the Medical University of South Carolina with Dr. Carolina Rocha and myself, and is also an active cornea cataract and lens refractive surgeon in Brazil as well. And so it's just a great group. We're both glad to be with you.
Well, I'm honored to have you. And also joining us for this conversation is Dr. Steve Wilson, who is a staff refractive and corneal surgeon, professor of ophthalmology, and director of corneal research at the Cole Eye Institute at Cleveland Clinic. Steve, why don't you kick off our discussion by telling us about your work with topical losartan?
I'm going to be talking about our work over the last 5 or more years on topical losartan for treatment of corneal scarring. The original idea behind trying losartan came to me in 2011 based on a paper I read in Science that dealt with an animal model of aortic aneurysm where myofibroblasts were involved, and losartan was effective in producing myofibroblast apoptosis in that model. And I was fully funded at the time and just kind of put that away as an idea. And then about 5 years ago, I started worrying about NIH funding and decided to apply for a DoD grant. And I focused on the potential for losartan. And our first trial was a desmetal rhexis, where a patch, 8mm patch of endothelium is removed in rabbits, and that causes extensive posterior corneal fibrosis. And I specifically chose that as our first model because I knew the epithelial basement membrane and epithelium would be intact in those eyes. And if it could work in those eyes, it could then work in anything. And it worked beyond my wildest dreams in the desmetal rhexis model. And subsequently, we've done many different models: PRK, late haze, alkali burn, incisions in the cornea. In all of those different studies in rabbits, the myofibroblasts were effective in removing, the losartan was effective in removing the myofibroblasts. And our recent studies, which are actually submitted and being reviewed, show that the losartan actually gets rid of most of the myofibroblasts that are in the corneal tissue within a couple of weeks. But you can't stop the losartan because if you do, the basement membrane is still defective, and the myofibroblasts will reaccumulate and the scarring will recur. So a really important thing about using losartan is sufficient time. I recommend that all patients that are started on it go for at least 6 months. If at that point, if they're not seeing any resolution at all, then I think the tendency is going to be to stop it. Although I think some of those might still respond if you went even longer. But if they've even partially started resolving, then I recommend continuing that 6 times a day treatment. And I think you'll see additional clearing of the scarring over time. Some people have advocated using it 4 times a day. Some patients will respond, and some animals will respond to 4 times a day. The problem is that not all of them will. And so if you start the patient on 4 times a day and it doesn't work, you think the losartan didn't work. Whereas if you'd been using the recommended 6 times a day, I think it would have worked. Another area is some people have our maximum dose that we've recommended of 0.8 milligrams per ml 6 times a day of losartan. Some people, mainly in Brazil, just started using it 8 milligrams per day, basically because a patient accidentally got that for 2 weeks and they didn't see any complications. But we have shown in a recent study that we've submitted that doses, even at 0.8 milligrams per ml, can have toxicity on the epithelium. That doesn't tend to have any effect on the treatment as long as the epithelium is intact. But in any patient where you're treating with losartan where they have an epithelial defect, either a persistent epithelial defect or a microbial corneal ulcer or traumatic injury to the cornea, I recommend now only 0.2 milligram per ml during the time the epithelium is not intact, because we did see some evidence in a rabbit study that we're submitting. If there's an epithelial defect present, there's an increased risk of getting a persistent epithelial defect, whereas we did not see that with 0.2 milligram per ml. So that's a new change in our dosing recommendations. Never go above 0.8 milligrams per ml 6 times a day. And if they have an epithelial defect, during that period of time, use it 0.2 milligram per ml and then 6 times a day. And then when the epithelium heals, you can go to the maximum dose of 0.8 milligrams per ml. That study showed that in patients with an epithelial defect, 5 out of 6 of the corneas treated with 8 milligrams per ml got even more severe numbers of myofibroblasts. So it worked the opposite. They got more scarring, and many of them got persistent epithelial defects, which is probably the reason for more scarring. It's not FDA approved yet, so all use of topical losartan has to be off-label. And the limiting factor for many patients is finding a compounding pharmacy that's licensed to make it in the state where they live. I'm not affiliated with any compounding pharmacy, but I'll tell you that, for example, there's a compounding pharmacy called Town and Country in New Jersey that ships to 16 to 20 states. So you could look that up and see if you're one of their states. But there are some states, unfortunately, where my understanding is it's impossible for patients to get it. So, for example, in Ohio, we get it from a compounding pharmacy in Columbus called the District Arena Compounding Pharmacy, and they ship to patients, but only in Ohio. So if you're in another state, the first objective when a patient contacts me is I tell him, you need to find a doctor in your own state who uses a compounding pharmacy in your state, or one that's licensed for your state, such as the one in New Jersey, and then you can receive the topical losartan. The cost, this is not covered by insurance because it's off-label and hasn't been through the clinical trials, which we're desperately hoping to get going in the near future, but we have to wait on the patents to get companies interested. Those were submitted a year and a half ago, so it could be any day now that we hear, but it could also be another year. So it's a very frustrating time for us. The cost for patients that I know of from different pharmacies around the U.S. is $90 to $160 per month plus shipping. And again, it's not covered by insurance. And our pharmacy, for example, sends a patient a 30-day supply of sterile 1 ml vial syringes. And the patient thaws out one of those a day, and they use 6 drops a day from that syringe. And then the next day they go on to another syringe. And that, my understanding is that way of sending it to patients was mandated by the FDA recently. And that's why it's being sent that way, frozen. In Brazil, for example, it's on the shelf. It appears to have a very good shelf life, and they're selling it in bottles and at a much cheaper price than we can get it here in the USA. But it all varies from country to country and even state to state within the United States. So I encourage more people in the United States. It seems like it's really taken off, topical losartan in Brazil and some other countries. And it's starting to do that here in the US. I'm getting more and more emails all the time about, how you make this up. And I usually send them a review article I recently wrote that has all the details. But I just encourage you to try it. It works for traumatic scarring of the cornea. Any infection, you give them the normal infection regimen, say herpes simplex type recurrent herpes simplex. You give them the acyclovir, and some of those patients need some corticosteroid if the inflammatory response is great enough. But on top of that, you add the losartan 6 times a day to the regimen using the 0.2 milligram per ml while they have an epithelial defect, and then transitioning to 0.8 milligram per ml 6 times a day once the epithelium is healed. So that's basically all I have to say about it. If anybody has any questions, I welcome those.
Thank you, Dr. Wilson, for sharing your extraordinary work with us. And now we're going to shift to refractive indexing, which is truly a new horizon. This is an area of expertise for you, Dr. Waring and Dr. de Barros. So if you could just sort of explain what it is and its significance as an alternative to traditional corneal surgery techniques.
Well, Marguerite, I think you said it well. Refractive indexing, or RIS, refractive index shaping, does represent a potential new paradigm in vision correction, and it has broad applications. But to understand it simply, this is sort of a unique concept that we're not used to thinking about. So this is not an ablative procedure, and it's really not a shape-changing procedure in the historic sense of thinking. This uses femtosecond laser technology that is below a cutting threshold that we're used to using femtosecond lasers for, and it selectively changes the stromal matrix index, which is essentially a combination of water and collagen. And so this index between those two components historically is about 1.3 to 1.5, and so the stromal index combined is somewhere in between. So this selectively changes the stromal refractive index if we're talking about a corneal procedure, and creates a 3D shape within an optical structure. In the instance I was just referring to, that could be the cornea. But this originally was done on contact lenses and still holds promise for contact lenses. And then I think it's important we spend a little time talking about the intraocular lens applications. And that's not the human crystalline lens, but that's a pseudophakic crystalline lens. So this also can be applied to a pseudophakic IOL, whether it's in vivo in a human or before it goes into human, and customizes IOLs. So this has a potential major disruptive opportunity in our industry when we start thinking about IOL applications as well.
A person who was a little off on their refractive outcome after cataract surgery could get a tune-up with this. So this would be, in a way, a competitor to the light adjustable lens. How do you see those two fitting into the future, George?
Well, the light adjustable lens really was such an important offering to our current armamentarium. I mean, it's the first time we've been able to adjust IOLs in vivo, and so it really changed the landscape, tripling market cap last year alone in how surgeons approach vision correction at the time of IOL and after IOL implantation. So it, but it's a different concept. Light adjustability works with different physics, and this with refractive indexing, this is something that also can be done in an office with a femtosecond laser in a minimally invasive fashion, but it has a couple unique advantages and opportunities beyond light adjustability. For example, we don't need to protect ourselves from the UV, and that it's not a UV active polymer. Number two, the treatments can be repeated. And number three, it doesn't require sort of a lock-in period as well. So it's something that can be done in over to an extent to allow for changes or customization or reversal in a minimally invasive fashion. Again, and without having to wear the goggles and potentially increasing the flow and just kind of streamlines the process. With all that said, it's also much, much, much further upstream than light adjustability, which is FDA approved now for a number of years and has done quite well in the United States.
George, do you see this technology being able to touch up someone who's had, say, a monofocal IOL 20 years ago? Do you think that's possible, or do you think those materials from the past are not appropriate?
It's a great question, and the application, RIS works on most materials and intraocular lenses, but it's optimized in some materials more than others. And so it's really ideally suited in acrylic, and there are certain acrylics that even work, I guess, are better optimized for RIS. So really, depending on the lens, most lenses actually would be amendable to this and have been shown in early evaluation to work with RIS, particularly acrylics. However, some work a little bit better than others.
At the time of the treatment, are there any concerns about toxic release of any materials into the anterior chamber, for instance, in an IOL treatment?
Margaret, it's an important question because that's kind of those are the things that we start wondering about. But the neat thing about refractive indexing, regardless of the optical structure or substrate, is that it's encased within the structure, so it's protected. It's almost like, imagine, if you will, creating a 3D structure within an optical structure by selectively changing the refractive index in that shape. That's the best way to think about it. It's almost like seeing, a 3D printer. If you just say, okay, we want that optical effect, whether it's multifocality, extended depth of focus, sphere, cylindrical correction, Q value, reversal of multifocality. It's all encased. So that's a little more information than the question asks, but no, leaching and that sort of thing, that's really a non-concern with this because it's all within the material.
Oh, that is tremendous. How far up the pipeline is this technology before we could use it either on corneas or intraocular lenses, do you think?
It's still what I would call upstream on both in both applications, but there have been this has already been done for it's out of the lab. It's been done in pivotal or pilot trials in humans, and with surprisingly good success in both applications. And the so there are kind of all the next steps in the innovation cycle are all happening as we speak. So this is something that you and I are going to both see in our careers. It's not going to be tomorrow. It's not going to be anytime soon. But I do think this holds promise for the future, and I do think this is a real thing.
George, the humans who have been treated, the living humans, they've had corneal treatments and others have had IOL treatments. Living human subjects. Wonderful.
That's great. Now, to be clear, this technology, just a little bit on the background, this came from the University of Rochester in New York. That's I want to credit Scott McCrae and with a lot of the early lab work with this, and has really kind of been the champion and the pioneer in the area. In fact, Murray, you may remember he delivered the Bear Care lecture was on his work on refractive indexing in the cornea and some of the amazing things he's doing in the third world, which is really exciting when you think about that application. And we might have Dr. Barros talk about some of the benefits of the corneal applications and why that paradigm makes so much sense here in a moment. But the IP and the technologies really went two different directions, where one group was primarily responsible for lyric, and by the way, that stands for laser induced refractive index change, lyric, LIRIC. And then another group went the way of the lens, and that's the group that we've been working with for probably close to 8 years now on this project, on the lens work. And when I say lens, again, that's not the human crystalline lens; it's an IOL, and that's Perfect Lens is the company that has sort of championed the lens work. So these are separate projects that are in no way related except by the fundamentals of refractive indexing, and both have done their own first in human trials, OUS.
Wonderful. What country was the surgery?
Central America.
Okay, great.
Dr. Barros, maybe you could speak to some of the potential benefits of lyric and how it's different than what we have access to for corneal vision correction, and maybe some of the unique features and benefits of why it's so exciting for corneal refractive surgery.
Sure. So the lyric technology uses the femtosecond laser in a low level energy below the ablation threshold, and then create generalized modification in the corneal stroma, so alter the refractive index and can correct the refractive error. So I think the major and biggest revolutionary in this procedure is that doesn't have any cut or doesn't have any ablation in the corneal tissue. So it's a good opportunity for those patients that are not good candidates for the traditional laser vision correction, as the procedure doesn't thin the cornea. So for the patients with thin cornea, the lyric procedure it's a good option.
So thank you. In the few patients that have been done so far in Central America, how fast is their recovery, their visual recovery?
So the recovery is faster than the regular one because the epithelium remains intact and the procedure is in office, so doesn't need to use any antibiotic or steroids after the procedure. So the recovery seems to be much faster.
How about pain? There must be a couple of corneal nerves that get hit.
Actually, there's a really interesting publication, and that publication showed there's no nerve damage during the lyric procedure. So the procedure is unpainful, and the recovery is still unpainful.
So the surgery is not painful and the recovery is also
Unpainful,
not painful.
yeah,
Wonderful. Wow. Well, we can't wait to hear more about that.
yeah. It is an
We're going to,
exciting technology.
oh, oh, amazing. But we're going to move ahead to a comparison of the traditional and emerging techniques. Like, what do we think in the future will happen with PRK, LASIK, and SMILE? If you had to look in the crystal ball, George, what do you think will happen to those three procedures over the next 10 years?
Margaret, I think we're going to see a slow shift over time. I was I had a funny thought in the middle of the night about our topic as I was thinking about this and about the future of corneal vision correction is corneal vision correction is lens vision correction in some ways. I think we are going to be moving that direction, not totally, but I do think some of what we have been doing over the years in corneal laser vision correction will be moving towards lens-based vision correction, and that's both phakic IOLs and lens replacement, particularly for hyperopia and presbyopia and dysfunctional lens syndrome. Usually best to go to the source of the problem. Now, but I think LASIK, PRK, SMILE all will remain. I do believe SMILE will gain market share like we've seen. And a lot of times when we're looking to the future, we look outside the US because they're often ahead of us by a decade or more. There's very little LASIK done in Asia these days. So a lot of it's moved towards SMILE and phakic IOLs like the EVO. But we had a very unique opportunity just a few weeks ago to, in fact, it's the second time we've had the wonderful opportunity to do this. We just introduced the first excimer approved by the FDA in well over a decade with a new excimer laser. And then it was in 2009, I think. Was that right? Or 2012, we had the same opportunity to do the one before that. And it had been quite a while. So the excimer space is not evolving quick. The femtosecond space is evolving quick, whether it's SMILE. There was just a new high-speed femtosecond laser for SMILE introduced earlier this month. And that holds great promise. So, moving towards lenticular extraction, I think can make a lot of sense. But the LASIK procedures with these advanced lasers are so good, and now are treating on average a diopter in 1.2 seconds, and the recovery is quick. The outcomes we just are extraordinary. We've just submitted them for peer review publication for this recent laser introduced. So, I mean, it's just a really exciting time. And then, Marguerite, I might just flip the script if you would allow me and ask, you to predict the future with surface ablation and maybe talk about some of the neat innovations that you've been involved with with advanced techniques with surface ablation too, and maybe we can peek into your crystal ball and see what you think as well.
Well, I do agree with you. I think those procedures will still exist with better and better lasers, both femto and excimer. I do think lens surgeries will take part of the market. The EVO ICL is a very exciting addition to our armamentarium, and it's coming down lower and lower in the diopter scale as people become more and more comfortable with it. But the design change that resulted in EVO ICL was truly a game changer. And I agree with you, for hyperopia and presbyopia, it makes sense to address the problem. So I agree with all those things. As I said, the three more traditional LASIK, PRK, SMILE procedures will still be around, but all of them, including PRK, evolve and improve with time. So I do my surface ablations with the as the Epi-Bowman's keratectomy, EBK technique. This is a little disposable instrument, single use, no moving parts, that scoops up the epithelium in sheets. So fewer cell membranes are popped, fewer pro-inflammatory cytokines are dripping down into the stroma. It leaves not only Bowman's layer, but basement membrane. So you think, well, what difference does that make? You're going to shoot it all off anyway. But at the edge of the ablation, there is still intact basement membrane. And the reepithelialization speed is astonishing. People heal quickly. I have a perioperative regimen that helps, but their pain is much decreased. And the return of vision is actually comparable to LASIK. They usually walk in the next day 2025. So there is still a place for PRK, and it has improved tremendously. My perioperative regimen helps as well. They, of course, still get a bandaged contact lens till the epithelium heals, but there is a place for it. And what's interesting, too, is every country has a different profile. Like LASIK is really big in Asia. There are other countries where, believe it or not, more PRK is done than LASIK. I mean, every country has a different footprint, if you will, and it depends on a host of factors, economics, all sorts of market forces, patient preference. But even the traditional procedures that have been around for many years are still getting better, better, and better, as you said.
Well said.
Well, I can't thank you enough. These are very insightful contributions. And I think the key takeaways are that the future of corneal surgery looks very, very bright. And the innovations actually are exciting and staggering. And we have experts that have joined us for this chapter. So to learn more about the future of corneal surgery and the topics that we discuss in this episode, please visit www.crsttoday.com. And thank you so much for tuning into the CRST, the podcast.
For more shows like the one you just listened to, check out the podcast channel on itube.net.